coming to MR. In fact, there are 3 or 4 folders which will be not amalgamated, so there are separate folders. So this is one, I have to take help from others. Anyway, magnetic resonance energy. Okay, let me tell you the magnet. This contains the basic physics, the safety, applications, and if you have any questions. Okay? Basic physics. In fact, what we do in MR, just in what we measure in MR.
Movement of the hydrogen ions.
Basically, we are measuring the proton density or density of the hydrogen in the particular part. That is the resistance. We can measure all odd number of proton, but any atom with odd number of proton, that can be also picked up in it. The patient is put in a magnet of high tension magnet, and a radio frequency pulse is given to the body. It is withdrawn, and the signal ultimately is picked up as MR signal, or we call it signal or intensity. Okay. Basically, it's picked up, but what you have to know, what is T1 and T2 energy, what is diffusion energy. These are the things, especially those who are in the field of medicine, they have to know T1, T2, diffusion energy, because for stroke imaging, diffusion imaging has revolutionized the management and diagnosis of stroke. These 3 things should be kept in mind. Proton density or flare image, we call it flare, fluid attenuated inversion recovery. You don't have to remember all these jargons, because these are a bit tougher for you, and it is not possible when you look at the patient, you may not be able to concentrate on this physics jargon, but rather you concentrate on the patient's outcome and patient's treatment. Okay. And the basic part of it. Basically, the hydrogen atom or hydrogen ion is essentially it acts as a tiny magnet. Now, when our body is placed in high tension magnet, the hydrogen atoms or hydrogen ions, they align most of the major part of hydrogen ions. They are oriented horizontally in this posture or outside the magnetic field. But when they are placed in high magnetic, external magnetic field, almost all hydrogen ions, they align in a particular parallel orientation. Only a few are anti-parallel. Okay. That is number 1. Number 2, then why we use hydrogen? Because it is the hydrogen and water is abundant in our body, and it is having odd number of proton, and this acts as a tiny magnet. Okay. Also, we can use 13 carbon, 15 nitrogen, uh, 17 fluorine 19, sodium 23, phosphorus 31, but these are not used. This one is the most important thing, with odd number of proton or odd number of neutrons or both. They are utilized for MR. After in a magnetic field, they are basically major part, they are parallel and few are anti-parallel. And ultimately we get a main magnetic field or B0, what we call it. Now net mag, or that is net magnetization vector, that is an excess of hydrogen nuclei will line up parallel to BO or B0 and create the net magnetic vector of the patient. You don't have to understand this. Just skipping. And each nucleus also precedes. It moves around its own axis as well as the opals. like the earth moves, it opens like the spinning curve. Okay. Now we have to understand what is TR and T2. Now, the next part is resonance, because this should be a bit difficult. I shall try to be more lucid as far as possible in the next phase. Resonance occurs when an object is exposed to an oscillating perturbation, that is the frequency close to its own natural frequency of oscillation. We don't have to remember this. What we do is that the patient is placed in a particular magnetic field. Then we introduce the radio frequency pulse, almost of the same frequency or the magnetization of that hydrogen ion. And that energy is picked up. And immediately it is released. That energy, the radio frequency energy, that is released as signal, and through a complicated network of computers and software, which is displayed as a monitor, as an image in the monitor. Okay. We use a lot of protocols. In CT we use hardly 2 or 3 such protocols, but in MR we use a lot of protocols. In fact, this is very difficult for even an application specialist who deals with the MR machine. He doesn't know all the protocols. Every day 1 or 2 protocols are erupting. So what happens? What is TR and T1 and T2? Now you have heard the name of the coils in magnet. The body coils are basically radio frequency coils. Say for lumbar spine there is a lumbar spine coil. For cardiac there is a specialized coil, cardiac coil. For arm there is a small part coil. For brain there is a head coil. These coils are nothing but they put or they throw radio frequency pulse as well as they receive radio frequency pulse. The coils are nothing but this. Okay? Now as far as relaxation is concerned, there are 2 types of relaxation. One is transverse relaxation, one is longitudinal relaxation. You don't have to remember. Now, MR signal is basically, it is collected by the coil, encoded to a series of complex techniques and calculations, almost we call it a magic, stored as data and mapped onto an image matrix. Now, coming to TR and T. TR is repetition time, T is echo time. The repetition time, time from application of one radio frequency pulse to another radio frequency pulse. We say short TR, short TR. Long TR, long TR. Okay, I'll come. So T is echo time. Time from the application of the radio frequency pulse to the peak of signal induced in the coil. So just remember TR and T, only 2 things. So what is T1 weighted? A short TR and short T will result in T1 weighted image. So when you look at a film, MR film, we have to see the TR, I'll show you in this. Possibly this is kept in this folder. So in short TR and short T, it will result in T1 weighted image. It is excellent to delineate the anatomy. And long TR and long T result in T2 weighted image is excellent for demonstrating the pattern. In fact, we use a lot of protocols now about this. Say proton density image (PT) or FLAIR, fluid attenuated inversely coil, etc. But T1 and T2 weighted images and proton density or FLAIR images are 3 important things. I'll show you. Now T1 weighted image is like this, a sagittal image, where the fluid basically are as if you are looking at a CT scan. What you get in CT film, the same appearance is in T1 weighted image. 2 is very simple. And T2 is just the CSF is white or hyper intense in T2. So T1 weighted image, sorry, this is T2 weighted image, CSF is white and there is vision. Now, if you look at this one, What image it is?
So T1.
No, yes, T1, right, T1. Because look at TR, TR is more and T echo time, short T and short TR. Sorry, short, here TR is slightly increased because I'll tell you why. And how we look at what to see in the film, I'll show you in next few pictures. So here one thing is written contrast. After giving contrast, we have delineated a particular lesion. What contrast we use? We use a paramagnetic substance which is non-toxic to the body, especially gadolinium. Gadolinium DTPA, one of the safest contrast what we use. And all these protocols are taken in T1 weighted image. And during that time, TR is slightly increased. And FS means first sequence image. And so again, the same patient before contrast. With contrast, before contrast, this is T2. See, the TR is increased, echo time is also increased to some extent. It is 80. Usually we put it around 200 to 300. TR and T. So we are dealing with T2 at it. Again, same patient with contrast, the tumor outline is beautifully delineated. If you look at this one, see, the surrounding edema is suppressed. This is surrounding edema, the tumor, exact delineation of the tumor is possible after giving contrast. Okay? And the nature of the tumor, nature, what is inside, etc. Now what we look in a MR film is the top left corner, the machine parameter, examination number, series, image number. These are the important things what you have to check. On the top right hand corner, the patient's name, date and when it was done. And the important thing is the lower red corner. Left lower corner. What you have to look at? TR is 3000, so long TR. T is usually around 100 or 200. So long TR, long T equal to T2. So these two things you have to do. Only these two. You don't have to, you forget all this. Field of view, serial thickness, etc. Okay? So this part is important to see what type of image, TR or TE, you are dealing with. T1 or T2 images. This can be changed to some extent. Not that every time we are using TR of 3000 millisecond.
Sir, how much is short tier and how much is long tier?
It depends on the individual.
What is the range? What is the range? How can we understand?
Time is you have to be 80 or
Usually in T1 weighted image, we keep the T as low as possible. Usually 50 to 100.
up to 30 short.
In T2 it is usually 100 to 200 T equal time. And TR is above 1000 in T2 and it is below 500 to, 700 below 500 in T1 weighted image. TR is below 500. 700 to 500. So these are the things what we look at it. So now we are again looking at TR 3000, T echo time around 100. So this is a T2 weighted image what we have. Clear? Now as far as safety is concerned, how much safer is MR? MR we call it God's gift. Because it is one of the safest in this tube, but it has got certain hazards. What are the absolute contraindications of MR?
So metallic implants, pacemakers, clips.
Pacemaker?
So
Dentures, metallic.
implanted metallic clips.
And is it clip? But before 70. Before 70 all those aneurysm clips were ferromagnetic. And nowadays all are MR
So
compatible.
nowadays protected the pacemakers are from for the MRI.
In fact, in MR compatible pacemaker is available in our states.
So what
in the
is
states.
the
Important aspect that cochlear implant, the patients having cochlear implant, this is very costly instrument. As well as the procedure takes a long time, lot of manpower. Naturally, the cost is much more. If the patient has cochlear implant, he can't do. It will be totally different. Patient with pacemaker, it will be different. Patient with metallic implant. In fact, the patient had recent operation with metallic sutures or staples. This is not contraindication. This will not go out or it will act like a mistake. It's not that. It will produce some certain local heat generation, but it is not contraindication. Most of the departments usually, patient is having sternal suture, patient had cardiac CABG or any other stent introduction. All these stents are MR compatible. All the prostheses are there MR compatible. You can do safely, except these two contraindications. And the patient, if there is a long, narrow tunnel, separate, if it is not open MR, if the patient is claustrophobic, it is really very difficult to put the patient without sedation. And in fact, we the doctors, once you enter the patient or I enter the machine, I will not enter for the second time. Because of the sound it produces is more than 60 to 100 decibels. The different protocols, because the radio frequency pulses when it goes in different protocols or different sequences, this is extremely irritating.
So is there anything called MR with ambience? MR with ambience. Is there anything, any sort of thing, MR with ambience to reduce this claustrophobia?
Yeah, that is available. In fact, in Calcutta there are two such machines, one in Woodlands, one in the convention center, with wide open gantry. The tunnel length is less. The patient can read a book and playlist mind MR is possible, and the patient can relax. Okay, so whiteboard that causes less claustrophobia. And to suppress the noise, we introduce a music system, but it causes the disturbance in the radio frequency pulse and causes artifact. Okay, that's why, and it is costly. But most of the time, in fact, the patient, we put some earplug to the patient, and the patient can tolerate those noises. So naturally, the MR machines what are available in our is 0.2 Tesla to 1.5 Tesla, but in Calcutta 3 Tesla machines are also available, at least in 2 centers. And in the laboratory, we have produced a magnetic stent of 30 Tesla till date. Up to 30 Tesla, we have produced a magnet of 30 Tesla. Now, these are the strong magnetic field of the magnet can turn the following into dangerous projectiles. These are the things that wheelchairs, oxygen tanks, IV keys, coins, scissors, trauma boards, sandbags, safety boots. Monitoring equipments, infusion pump, credit card, cellular phone, any electronic device, including the metro ticket, they will be damaged if you enter in the high magnet. Always, and remember, the magnet, once it is on, unless, especially the superconductor magnet, unless the helium is absolutely evaporated, it becomes almost an iron. There is no more a magnet. But once it is on, it is always on. So when you enter any MR unit, be aware of your credit cards, metro ticket, or other important electronic, magnetic strip devices, as well as the cell phone, and a few watches which are having still radiance. But these are safe. Gold, silver, digital watches, frames, dental dentures, these are not being affected by this. With high magnetic. So in MR, what we get is excellent soft tissue contrast resolution, no ionizing radiation. There is no side effect. without moving the patient, you can get sagittal, coronal, axial, or in any desired oblique plane section. Okay? It is non-invasive. Even vascular studies, especially neck and cranial vessel, that can be done without putting any contrast. Okay? So, as far as in fact, arthroscopy, unless for operating or intervention, arthroscopy has lost its so-called glamour after MRI. Because MRI can show every detail what is happening inside a joint. Similarly, you can pick up non-invasively any vascular anomaly or normal vascular structure, especially the intracranial vessels. Similarly, neck vessels can also be delineated. With contrast, it is better delineated, but without contrast also, it is possible to pick up the neck vessels beautifully. For renal angio, similarly, say for donor or any renal artery stenosis, this is one of the important investigations, but we prefer CT angiogram. And as far as GAD is concerned, this contrast what we use for detection and typification of tumor, infection, inflammation, post-traumatic changes, post-operative changes, and MRI, especially the peripheral vessels. For post-operative changes, gadolinium is useful because a post-operative scar or recurrence cannot be distinguished without the help of gadolinium. If there is post-operative residual, scar, it will not enhance. If there is recurrence of tumor, but you are not sure, put contrast, it will enhance. Okay? Now, the disadvantages are a bit expensive. The noise is really sometimes intolerable, and the patients who are claustrophobic or the patients with multiple indwelling channels, they cannot be taken, or the patient with acute injury and patient is moving, they cannot do M1 because each protocol takes around 3 to 4 minutes. Whereas the CT, we can finish CT in 10 seconds. Entire head CT I can do in 10 seconds in my machine, which is only a dual sensor. Actually, some patients with pacemaker and certain implant like cochlear implant. These are the disadvantages. Okay? As far as brain is concerned, dating of hemorrhage is important. With CT, we say yes, it is a resolving phase of acute, etc. But for dating of hemorrhage is important. For any white matter lesion, especially multiple sclerosis, is investigation of choice. And put gadolinium, if it enhances, you can see the activity. And after therapy, how much is the progress of treatment? Okay? Other neoplasm, trauma, especially diffuse axonal injury. CT is absolutely normal. A1 will pick up diffuse axonal injury. That is the most important part, which causes severe damage, which is not visible in CT. And vascular deformations, like, in fact, I have given a printout on maxims. There are certain maxims is given. This may give copy, and especially different types of vascular malformations, they are picked up much better in MR without giving any contrast in. Okay? So in brain metastasis, pituitary